No lights. Is on? Is it on? Hi, everyone. We're going to get started with the next segment of our section. My name is Paige Griffith. I'm a nurse practitioner at Johns Hopkins. I also have the privilege of being the chair of the Nursing Advisory Board of the Cholangiocarcinoma Foundation. So what we wanted to do today was do two small segments that break down some more information. I know you guys have had a lot of information, and I'll let them introduce their segments, but I wanted to introduce myself, what the Nursing Advisory Board is, and then the members that we have on our team. So the Nursing Advisory Board is a group of advanced practice providers. So this is nurse practitioners, physician assistants, and nurses who specialize in the care of patients with cholangiocarcinoma throughout the country, with the goal to improve outreach and education for patients and those who care for patients with cholangiocarcinoma. Our hope is to have more members on board that can reach throughout the country at small centers, big centers. And so if anybody has a nurse or advanced practice provider that they think might be interested in, please reach out to the CCF. So I introduce myself. I care for patients with HCC and cholangiocarcinoma at Johns Hopkins Hospital, like I said. On our board, we have Leslie Swanson. She's a nurse practitioner in medical oncology at the Fred Hutchinson Cancer Center in Seattle, Washington, and she's going to present today, as well as Jen Wild, who is an MSN RN in GI medical oncology at UCSF Helen Diller Cancer Center in San Francisco, California. Two other members that are here sitting in the back with us, we have Julie Palmer-Hoffman. She's a nurse practitioner in palliative care at the Smilow Cancer Center at the Yale New Haven Medical Center in New Haven, Connecticut. And lastly, we have Caitlin Musto, who's a physician assistant in interventional radiology and transplant surgery at the Mayo Clinic in Jacksonville, Florida. So we cover a lot of different groups. We're really proud of what we've accomplished and hope that we can reach more of you. So, Leslie.
Thanks, Paige. My name's Leslie Swanson. I'm a nurse practitioner from Seattle, Washington. It's great to be here with all of you today back in my home state. We are going to take the next 10 to 15 minutes to look at the treatment landscape for cholangiocarcinoma. Some of this is going to be a little bit of a review as we've talked about some of the information, but hopefully we'll touch on a few new things. So just a brief background, cholangiocarcinoma encompasses all tumors originating from the tissue of the bile duct. Based on their location, we can classify them as either intrahepatic or extrahepatic. Extrahepatic cholangiocarcinoma is more common than intrahepatic cholangiocarcinoma and accounts for approximately 70 to 80% of cases. Our perihilar cholangiocarcinomas, which occur at or near the junction of the left and right hepatic ducts, are the most common type of extrahepatic cholangiocarcinoma. So the first part after being diagnosed is looking at staging. We traditionally have our stage 1, 2, 3, 4, which we often hear when we find a family member or friend that's diagnosed with cancer. When we think about how we approach treatment of cholangiocarcinoma, sometimes I feel it's easier to divide it up into buckets. Looking at whether it's resectable, meaning can we remove this tumor with surgery? Or is it unresectable, locally advanced, meaning that the tumor is not spread to other sites, but it may be too difficult to remove. Or we have our metastatic disease, meaning it's spread to other locations. The way we determine which bucket we fall into is determined by, one, the primary size of the tumor, whether there's presence of regional or distant lymph node metastases, vascular or surrounding structure involvement that may make surgery more challenging, or the presence of distant metastases. In order to accomplish staging, we utilize imaging, with the standard being a CT chest and a multi-phase contrast-enhanced CT or MRI of the abdomen and pelvis. I commonly get asked about PET CTs, which are not currently the standard, but they may be considered if there's an equivocal finding on prior imaging. And then also an important part of staging is biomarker and tumor marker testing. Often this is like your CA 19-9. This slide is just a quick summary, kind of another way to approach that initial question, is this disease resectable? About 80% of cases at the time of diagnosis are unresectable, leaving about 20% of patients able to proceed with surgery. So when we talk about surgery, Surgery is the only potential curative treatment for patients with resectable disease. The goal of surgery is a complete resection with negative margins, meaning that when we remove that tumor, there is a border of clear cells that are negative for cancer. We also look at regional lymphadenectomy and making sure that we leave behind an adequate future liver remnant so that patient can continue to live with a functioning liver. Surgical management is based on the location and the extent of the tumor. It's done in the absence of distant or metastatic disease, and it is very strongly recommended that evaluation at a high-volume cancer center that specializes in cholangiocarcinoma. Unfortunately, even after surgery, approximately 50% of patients will have recurrence of their cancer within the first year. So how do we improve outcomes for patients so that these surgeries can lead to longer lives and more time with friends and family? Chemotherapy or neoadjuvant chemotherapy given prior to surgery helps improve outcomes by increasing the chances of a successful surgery and reducing the risk of cancer recurrence. This is not quite standard yet. However, we often are having these conversations on a multidisciplinary team for patients with high-risk factors, including larger tumor sizes, vessel involvement, or higher tumor markers at the time of diagnosis. So after surgery, we also have the potential to intervene and help prevent the cancer from coming back. And the way we do this is by giving adjuvant chemotherapy. There have been a few trials that have provided evidence to support the use of adjuvant chemotherapy. The BILCAP study has the highest level of data supporting its use. And based off of that data, the international guidelines recommend 6 months of adjuvant capecitabine or an oral chemotherapy course. There have been some studies, however, the data is limited and not quite clear on the use of concurrent chemoradiation. So the current recommendation is to use this on an individual basis. For example, patients who have margin-positive disease. So let's get to the 80% of patients that are diagnosed with unresectable and metastatic cholangiocarcinoma. Once that surgery is not determined to be possible, biopsy is recommended to confirm diagnosis. That biopsy is also very helpful in terms of setting the stage for future treatment to come. We know that cholangiocarcinomas, particularly our intrahepatic cholangiocarcinomas, are molecularly diverse, and it's very important to obtain molecular testing at the time of diagnosis. This testing should include microsatellite instability, mismatch repair testing, tumor mutational burden, and then other additional molecular testing like NTRK gene fusion, FGFR2, IDH1, HER2, and many more. Using next-generation sequencing allows for testing of many genes with one test, and by completing this testing, patients with specific genomic mutations may be eligible for targeted treatments. So when we break down the principles of treatment for advanced cancer, the mainstay of treatment is systemic therapy, and that could either be chemotherapy, immunotherapy, targeted agents, or clinical trials. Radiation, either palliative or in combination with chemotherapy, could be considered. All patients should be evaluated by a multidisciplinary team prior to initiating treatment. Palliative radiation may be utilized to help manage symptoms associated with local tumor effects. There's currently limited clinical trial data to define a standard regimen or definitive benefit of chemoradiation. We have external beam radiation or stereotactic body radiation therapy concurrent with chemotherapy that may be utilized in hilar cholangiocarcinomas. And then we have our local regional therapies that may be a good treatment option for patients with disease confined to the liver. These local regional therapies have been shown to be safe and effective in a small retrospective series of patients with unresectable cholangiocarcinomas. However, due to the rarity of this disease, none of these local regional approaches have been evaluated in larger random controlled trials. The NCCN guidelines do recommend local regional therapy as a treatment option that may be considered for patients with unresectable disease. And these treatment options can include TACE or Y90. So when we talk about systemic therapy for patients, this was talked about a little bit earlier. For the longest time, we've had gemcitabine and cisplatin, and in 2022, we had the addition of durvalumab after the TOPAZ-1 trial. This is still our first line standard treatment option. In the second line, we have FOLFOX, and in 2021, a phase 2 study suggested some benefit for patients with 5-FU plus NAL-ERI. And we will anxiously await the data presented on Sunday regarding the potential for GemCis plus pembrolizumab. This is my favorite slide. It's very busy. It really drives home the fact that our treatment options are growing. And by gathering more information through molecular testing, we open the door to more treatment options. So on the left, we still have our first-line therapies with a combination of chemotherapy plus immunotherapy. And in the second line, for those who don't have any targets, we have our treatments of FOLFOX and 5-FU NAL-ERI. However, with molecular testing, we can now identify specific pathways that are driving cancer growth and learn how to directly target them to halt that growth, control the cancer while sparing normal cells, and reducing the toxic effects of chemotherapy. I want to highlight the FGFR2 fusion, IDH1 mutation. These are our most common. And with our FGFR2 fusions, these drugs had a high response rate in their trials of close to 35%, which is actually better than what our first-line therapies do. So they are very promising for those patients. The IDH1 mutation had a lower response rate. However, it's being used to control the cancer by giving us time where we can have that quality of life, less symptoms, and prolong our lives. And then we have our MSI high patients where we're getting those immunotherapies that we talked about, and we have that great video. And just to summarize, we have many, many factors that influence treatment. Not every case is the same, and that's where this treatment of cancer is changing, where we're trying to do precision medicine, taking patient A and treating their tumor specifically, patient B treating their tumor specifically, because we know that we can't do the same approach to everyone. And so this is just a great way to approach how we make treatment decisions. Thank you.
Hi, everybody. I want to thank you all for being here. And I also want to say thank you to my mentors, Dr. Katie Kelly and Dr. John Gordon, who I have the immense pleasure of working with. And they will be here tomorrow. So, great. We're going to start talking about biliary brain metastases. And this presentation, like earlier ones today, is geared specifically for patients and caregivers. If you are interested in any of the scientific numbers and graphs and things, feel free to find me later. So first, since many of you have maybe had your surgical resection and did not ever have the unfortunate news that you have a metastasis, let's just recap really quickly for some of you. What is a metastasis? Cancer.gov, the NCI, defines it as cancer that spreads from where it started and moves to a distant part of the body. How does this happen? The primary cancer, so in this case biliary, it jumps on the highway and it looks for a really nice off-ramp that maybe takes it to a new place for a new settlement. And it takes these highways in the sense that it's entering your bloodstream or the lymphatic system. When it finds this new place, we call that the metastasis. And the cancer can even, it does all kinds of tricky, sneaky things, but the main thing that it does to sustain its growth is that it makes new blood vessels grow to sustain this new settlement, so to say. Now, crucially, metastasis is not a second cancer. I get this question a lot from newly diagnosed patients. Does this mean I have bile duct cancer and lung cancer? And the answer is no. When you have a metastasis, we still consider it to be the primary cancer, meaning if you were to biopsy a metastasis and if you were to compare the slides in a lab, we would see that the cells look almost the same. You know, they don't look like lung cells or brain cells. They still look like biliary cancer cells. Cholangiocarcinoma most commonly enjoys metastasizing to liver and lungs if it metastasizes, and also to the peritoneum, which is a word for the lining that kind of holds all your things together in your gut. It kind of lines the bowl of your abdomen, keeps everything in place. But less commonly, although well known, we know that cholangio also likes to spread to the bones and rarely to the brain. So now I would like to share some of the research that I've worked on with Dr. Kelly. This was a retrospective data analysis, meaning there was no treatment involved. We don't have control groups in this type of a study. A retrospective data analysis is when we look at the data that we've collected in the past and say, what is the story the data is trying to tell us? So this was a collaboration actually with Stanford, who are right down the road from us, with Dr. Gebhardt, who's a neurosurgeon there. And we were able to combine 3 different databases of information, 1 from Stanford and 2 from UCSF. And between these 3 databases, we had information going back for a total of 30 years. Even in this huge database, we only found 15 patients that had definitely had primary biliary cancers that had metastasized to the brain. 10 of them were cholangio and 5 of them were gallbladder. Now they are super rare, but they are generally a very poor prognostic indicator. So first in the Stanford study, that data set gave us, I believe it was 3,500 cases of solid tumor brain mets. And so from this data set, we're looking at all of the different tumors that had spread to the brain. How many of those patients were biliary? The majority of them are lung, breast, and melanoma, which altogether, those 3 diagnoses, I think accounted for about 75% of all brain mets. Only 0.17% account for biliary. Now, if we look at data from the other direction, if we look at all of the biliary cancer patients that came through UCSF in a 30-year period, regardless of whether they were metastatic at all, regardless of where they were metastatic to, only about 0.85 to 1.43% of them had brain mets at some point in their cancer journey. So these are both very small numbers, but significant. Not something we can ignore, not something we can say is just a fluke. And unfortunately, 2/3 of all these patients passed away within 90 days of the discovery of their brain mets. The median overall survival for these brain met patients was only 57 days. There were some patterns that we recognized among this data set. So there were 2 main what I'll call inclinations, I guess, or like things people had in common. One of them is that people had high-grade tumor histology. This means that when we look at the cells from your cancer on a microscope, how well differentiated are they? When your cancer is well differentiated, we call that low grade, and it means that you can see that, okay, they're cancer cells, but they don't look that different from your normal cells. You can tell where one cell ends and another cell begins. Whereas poorly differentiated or undifferentiated cancers, we call those high grade, and those look very, very different from your normal cells on a microscope. They sometimes are so poorly differentiated that you can't tell where one cell ends and the next one begins. They have extremely, they may have polymorphic nuclei. They look weird. So if you have high-grade histology, that typically means you have poorly differentiated cancer. And we found that 80% of the brain mets patients had high-grade pathology, whereas if you look at all biliary cancer, only about 40% of all of our biliary cancer patients have high-grade. The other interesting characteristic is that 86% of these patients were female, and this does support other research in this that has tried to look at the demographics of who gets biliary brain mets. Our study was, to our knowledge, the first one that looked at the representation of biliary brain mets among all solid tumor brain mets. And it is importantly one of the only studies that is more than just a singular case study of one person who had brain mets in the United States. There are some other case studies that look at multiple patients in the same paper, but many of those studies are not from the United States. They're from other parts of the world, and many of them are very small. They're case studies that only look at 1, 2, or 3 patients and don't really have a large data set to tell us a bigger picture. So 86% of them being female. Other studies, one of them 50% were female, but all the other studies, case studies and retrospective analyses were either majority female or was just a single case study and the person was female. To compare and put this into context, about 56% of biliary cancer patients are female. So this is a very significant overrepresentation of female patients. So early detection is really important when you hear me say this really sad statistic about the overall survival being less than 3 months for most people. So what are the symptoms? What are the warnings that I should be looking for? Most of these things on this slide are related to or believed to be related to the increased intracranial pressure. So when you have this tumor in your brain, it's creating this increased pressure on some of your nerves and on some of the other structures in your brain, which can cause nausea, especially when you first wake up, headache, especially when you are vasovagal maneuvering or waking up or sneezing or coughing, vision changes, specifically vision changes that are sporadic or intermittent or may seem positional depending on how you're sitting or standing. Focal neurologic deficits, meaning you may have weakness in just one of your limbs or in a part of your face or your tongue, and personality changes. I think in our case studies, the most common problems were these vision changes, were sometimes the first things that people noticed, and also what we call in medical terminology AMS, or altered mental status, where a person's personality changes, maybe they're a little confused, maybe a little more reserved when they're normally more animated and more engaged. So what can we do for this? Unfortunately, this is an area where we need to do more study, but we're really focused here on palliative treatments. And by palliative, I don't necessarily mean hospice, although that is a conversation that should happen at this time point when a person is found to have brain mets. But by palliative, we mean how do we try to control the symptoms as much as possible? Corticosteroids play an important role. Some people also get radiation therapy to their brain. And we also, at this point, want to engage hospice if we have not already. Sometimes we use irinotecan-based chemotherapy because irinotecan can cross the blood-brain barrier, although not all patients are functionally well enough to receive irinotecan. And surgery is not advised at this point. So you might be saying, when I rehearsed this for my husband, he goes, well, that's delightful. So why am I telling you all this if it's so rare? Because it's something that you should know what to look for. It's like safety preparedness. You always want to know where your emergency exits are, how to get off the plane when an emergency is happening, but how often are you going to be in a plane crash in your life? Hopefully never, probably never. It's very rare that you will get brain mets. I hope that nobody in this room ever gets brain mets, but you could, and it's important to know what to look for so that you can act quickly. Additional discussion from the study, we may expect that the incidence of brain mets will go up in the future because as we have all these targeted treatments and people are living longer lives, there's more time for them to potentially develop brain mets when in decades past they might have already passed away because we didn't have these life-extending treatments the way we do now. We don't know yet if there are any links to tumor genetics. Many of the patients described in our case series had mutations, but many different mutations. There was no pattern identified there. And we also should study what different survival benefits there may be from different treatments, from different kinds of radiation versus different kinds of corticosteroids in combination with radiation. So in summary, brain mets are rare. They affect females more than males. They do carry a very poor prognosis in terms of time remaining from the time point of diagnosis of the brain met. And the takeaway message here is that, especially if you're a female patient and you know you have high-grade tumor pathology, you should tell your oncology team if you have new neurologic symptoms. And I believe now we're taking questions, right? Thank you.
No. Oh, there it is. I think, thank you to both of you for presenting that. I think brain metastasis has come up more frequently. Some of our clinical trials that we have had have included brain imaging as a baseline, and so why is that included? And this is why. So I think it's an important topic. I know it's not one that many people want to talk about, but we're seeing it more and more frequently in clinical trial screening eligibility also.
I have a question from a patient who is asking if chemo fails and now they have METs, does that make them no longer eligible for surgery? Do they have any stats on this?
Can I clarify the question?
You can.
So meaning if they initially qualified for surgery for their for their cholangiocarcinoma and then they find that they have a brain metastasis, would they still do the liver surgery? I think typically in most cases, no, because patients don't go to surgery if they have metastatic disease. There are surgeons that would do so depending on symptoms. If you can have surgery to treat the brain metastasis, that would be a rare incidence where you can do more aggressive therapy in the brain that they would use for other types of cancers like surgery, which isn't typically recommended if there's widely metastatic disease. But I would say in most of these cases, patients are not going to have a locally resectable tumor in addition to a brain metastasis.
Yeah, that's a great question. I know that in other solid tumor areas, they do sometimes do partitioning where there is some, we can't go into it right now, but it's a brain surgery. But for our patients, a lot of these patients in the studies, they have cerebrospinal fluid that shows they have, their cancer is spread. It's not just one tumor, it's kind of, you could resect it, but it's going to come back, and then the risks and benefits of surgery versus the amount of time you have left, and do you really want to spend that time in rehabilitation? And yeah, it's a I don't think a great option.
Thank
But
you.
great question.
He'll turn it on in the back. Just go ahead.
When you're looking at the pathology after a liver resection and you're seeing perineural involvement, are you seeing more brain mets with that?
That's a great question. I don't think there was a difference with, and you said with hilar involvement, was that the?
Perineural.
Oh, I'm
No,
sorry.
perineural.
I'm sorry. No, there is no difference if there's perineural invasion. No. Great question though, because of
see
the
the
keyword.
link.
Yeah.
Any other questions for the Nursing Advisory Board members? If you've got questions, this is the time to get them answered. Got your experts up front. Okay.
Oh yeah.
Oh, yep.
Those of us who are nurses, not advanced practice nurses, how is it that we can help you? I'm a patient, I am a doctorally prepared nurse. How do we help you reach patient constituents that we have access to or care providers that I teach as my example to get more information out? What would you want us to do?
I think a lot of what we need from the patients and the caregivers is wondering what you do actually need. Where are the deficits of the information that already exists? I think the CCF website is one of the best initial resources, and how can we expand from that? But I don't know that we know what, we think we cover things well, certainly, but there's obviously gaps, and ones that are patient-focused, not so broad, not so scientific, and I think that's what we're trying to reach. So, I pose that question back to you all, is what are those gaps that you need from, whether it's the time of diagnosis or is, there's a lot of stuff from initial diagnosis done by CCF, but is it stuff for later on in treatment? Is it support, palliative care, hospice, things like that? I think the perceived gaps and the actual gaps are different.
Because there are several nurse patients who are in treatment or NED or had surgery or not, and I think we can certainly help you guys get your message out.
I would just encourage people to keep asking questions. I know the first couple of visits, when I'm meeting a patient for the first time, those initial visits are overwhelming. You don't hear the information, even though you're being talked to, and for an hour or 2 hours at a time. And oftentimes you go home and then you start thinking of all these questions. And I just encourage patients and family members, and you have a lot of people who care about you, and if they have questions, even if it seems out of the box, bring them up, because that's the only way we drive new research, new care, and how we really can help each individual person.
Sorry, this wasn't about drains and stents. I know that's what the agenda said, and I think some people really wanted that, but.
There will be more on stents and drains.
Any more questions? Thanks.